Let's talk acute pancreatitis. Today, we're taking those dense, shifting medical guidelines and cutting-edge trial data, and we're translating them into a practical, life-saving visual map. If you've ever felt totally overwhelmed by the conflicting advice flying around the wards, you know exactly what I mean. You are absolutely in the right place. We're going to cut through the noise and focus purely on what the evidence is actually telling us right now.
So here's our game plan for this explainer. We'll start with the bimodal threat, trace the etiology and the cascade, cover diagnosis and biomarkers, then hit imaging and severity scoring. Finally, we'll wrap up with the really exciting stuff, the new treatment paradigms and the step-up approach.
All right, part 1, the bimodal threat, phenotypes, and mortality. We really have to understand what we're up against here. Because acute pancreatitis, it's not just one uniform disease. It presents a very distinct dual-phase threat to our patients.
Now, thankfully, about 80% of cases are mild interstitial edematous pancreatitis. You know the ones. They're self-limiting, resolve in about 3 to 7 days, and they generally don't cause organ failure. But we really need to hyper-focus on that remaining 20%. These are the patients developing necrotizing pancreatitis, which requires incredibly complex ICU care and carries, frankly, a terrifyingly high mortality risk.
And this dual nature is exactly why that 20% is so dangerous. The mortality curve actually has two distinct peaks. It peaks early, usually within the first 14 days, and this is driven entirely by a sterile systemic inflammatory response syndrome, or SARS, which leads to multi-organ dysfunction. But if the patient survives that early hit, they face a late mortality peak beyond day 14. That second peak, that's driven by infected pancreatic necrosis and septic shock. Recognizing these two distinct battlegrounds is literally the foundation of modern care.
Moving on to part 2. Etiology and the cascade, from the acinar cell right down to systemic shock. Now that we know the clinical timeline, let's zoom in microscopically and see what actually pulls the trigger here.
Look, every case starts with a trigger, right? The two main heavyweights here are biliary lithiasis, which causes roughly 40 to 70% of cases and is often flagged by an ALT level over 3 times the upper limit of normal, and alcohol abuse, making up another 25 to 35%. That's where toxic non-oxidative metabolites basically sensitize the pancreatic cells. Sure, we've got other culprits too, like hypertriglyceridemia, where triglycerides shoot past 1,000 milligrams per deciliter, or hypercalcemia. But honestly, regardless of the trigger, the initial insult attacks the exact same victim, the pancreatic acinar cell.
So how does this build into a deadly 3-phase cascade? It kicks off in phase 1 with pathological calcium overload right inside the acinar cell. This causes the enzyme cathepsin B to prematurely cleave trypsinogen into active trypsin, and boom, that ignites phase 2. We get localized autodigestion, where enzymes like elastase cause severe hemorrhage and coagulative necrosis. It's basically digesting itself. Finally, the inflammation breaches the pancreas entirely, triggering phase 3. That localized fire erupts into a massive systemic cytokine storm driven by NF-kappa, causing widespread capillary leak, ARDS in the lungs, and acute kidney injury. It goes from a single-cell problem to systemic shock with terrifying speed.
Part 3. Diagnosis and biomarkers. Confirming the threat quickly. With that systemic cascade in full swing, rapid and accurate diagnosis is our absolute first line of defense, because obviously we can't treat what we haven't identified.
When you're confirming this, you've got to prioritize the right blood work. There's a really stark divergence between lipase and amylase curves over a 14-day window. The golden rule here, always prioritize lipase. It has a significantly longer diagnostic window and way higher sensitivity. The rapid drop of amylase within the first few days risks some incredibly dangerous false negatives, especially if your patient is a late presenter.
But hey, an elevated lipase isn't the whole story. We use a diagnostic exclusion matrix to rapidly rule out other fatal acute emergencies. For acute pancreatitis, you're hunting for that classic, boring epigastric pain radiating straight to the back, combined with a lipase level greater than 3 times the upper limit of normal. Contrast that with, say, the rigid board-like abdomen of a perforated ulcer or the tearing flank pain and dropping hemoglobin of a ruptured AAA. Accuracy here dictates absolutely everything that follows.
And please, do not underestimate a good old-fashioned physical exam. Classic signs literally map the internal damage right on the skin. Cullen's sign around the umbilicus or gray turners on the flanks, these aren't just medical trivia for your boards. They're a visual roadmap of retroperitoneal hemorrhage tracking through ligaments and fascia. Spotting these instantly alerts you that you're dealing with a severe, potentially necrotizing course.
Which brings us to part 4,
imaging and severity scoring. Because timing is everything. Once we've got a clinical diagnosis, the knee-jerk reaction is usually to rush the patient straight to the CT scanner. But hold on, timing is absolutely critical here. Here is the absolute golden rule. Scanning too early is dangerously misleading. Firing up a contrast-enhanced CT within the first 48 hours is notoriously bad for underrepresenting the true extent of tissue death, simply because the necrosis hasn't fully demarcated yet. You really have to hold your nerve. Wait that 72 to 96 hours for the optimal window. But while we wait for that perfect scanning window, we aren't just sitting around. We objectively monitor patient deterioration using the modified Marshall system. This completely removes the guesswork by strictly defining organ failure with scores of 2 or higher. For instance, a PaO2 to FiO2 ratio under 300 for respiratory, a serum creatinine jumping over 1.9 for renal, or a systolic BP dropping under 90 for cardiovascular. If any of these hit a score of 2, boom, the patient is in organ failure and their severity classification instantly shifts.
When we do finally image the patient, the timeline still dictates what we're actually dealing with. The key morphological milestone here happens right at the 4-week mark. Under 4 weeks, we're dealing with acute peripancreatic fluid collections or acute necrotic collections. Basically, there's no defined wall yet. Fast forward beyond 4 weeks, and the body has had time to build a mature fibrotic wall. That gives us encapsulated pseudocysts or walled-off necrosis. Knowing exactly what stage you're in entirely dictates your next surgical or endoscopic move.
All right, Part 5, the new treatment paradigms. This is where we bust some historical dogmas. We've graded the severity, we've mapped the damage. Now let's talk treatment. Honestly, some of these old practices have been secretly harming patients for decades. Let's start with fluids. For years, the gold standard was fluid flooding, literally pumping patients with 250 to 500 milliliters an hour to offset third spacing. But the landmark 2022 waterfall trial completely shattered that idea. It proved that aggressive hydration actively harms patients, causing fluid overload in over 20% of cases compared to just 6% with moderate fluid. Today's modern paradigm demands targeted, moderate lactated ringers, precisely titrated to urine output and mean arterial pressure. We want to resuscitate them, not drown them. Next up, we absolutely need to abandon the whole concept of pancreatic rest, keeping patients strictly NPO to supposedly calm the pancreas. Actually, starving the gut causes severe mucosal atrophy, which just acts as a red carpet for intestinal bacteria to translocate right into that necrotic pancreatic tissue. The new standard is early enteral nutrition within 48 to 72 hours. Putting food into the gut maintains those vital physiological tight junctions, drastically reducing fatal sepsis. So feed the gut to protect the patient.
Now here's an absolute rule you must memorize, and honestly, be ready to defend it on the wards. Never, ever prescribe prophylactic antibiotics for sterile necrosis. I know it's incredibly tempting when you're staring at a spiking fever and SARS, but early antibiotics do not prevent infection. They just breed incredibly dangerous multi-drug-resistant bugs and horrific fungal infections like Candida. You wait until you have pathognomonic gas bubbles on a CT or a clinical picture of true sepsis before bringing out targeted antimicrobials like carbapenems.
Finally, Part 6, the step-up approach and modern surgical management. So if we aren't drowning them in fluids and we aren't blindly throwing antibiotics at them, how do we handle it when necrotic complications actually get infected?
We use the modern algorithm known as the step-up approach. Step 1 requires some serious patience. You wait at least 4 weeks for that walled-off necrosis to mature. Step 2 is minimally invasive drainage, either endoscopic or percutaneous. And get this, amazingly, about 35% of patients resolve completely right here without ever needing an operation. We only proceed to Step 3, minimally invasive necrosectomy, if they fail to improve. Open surgery? That's strictly a last resort salvage therapy now. And the data backs this up beautifully. The PANTER intention trials prove that this step-up method slashes major complications in death from 69% all the way down to 40% compared to those traumatic open surgeries of the past. On top of that, favoring an endoscopic approach gives you significantly fewer fistulas. We're talking just 8% compared to 34% surgically. It is a massive, massive win for evidence-based care.
We've really seen how acute pancreatitis care has completely transformed through rigorous evidence. We're finally shifting away from those aggressive, knee-jerk interventions and moving toward measured, precise, stepwise care. Which leaves me with a final thought for you. As medical dogmas evolve, what other entrenched historical practices in your daily clinical routine are just secretly waiting to be overturned by modern science? Stay curious, keep following the data, and I'll see you in the next explainer.